Hi, welcome to my presentation. Today it is called the Methadone Debate, and my name is Cynthia Burnett. So, what is methadone? Well, firstly, I just wanted to mention that I chose this topic because I have worked in an agency for the last few months, and I have been interacting with people who are on the MMT program on methadone, and I really wanted to learn a little bit more about this in terms of improving my understanding and perhaps improving the way that I can interact with people. So what is methadone? It's a long-lasting synthetic opioid. It was discovered in the 1930s by two German scientists, Earnhardt and Brockmel. So interestingly, and making sense, during World War II, there was a shortage of morphine, and this chemical was synthesized, and it was called, at the time, the brand name in Europe was L-polamidone. So after World War II, a U.S. company purchased the rights of L-pol from Germany, from these scientists, and they introduced it in the U.S. in 1947 and called it methadone. So it was introduced as a pain-relieving medicine for a variety of conditions, and it was very effective. So by the 1960s and 70s, though, there was this idea that methadone could be used in the treatment of opioid addiction. And through the 1960s and 70s, regulations were developed regarding the methadone maintenance program, or MMT, that would be used as a treatment for opioid addiction and opioid misuse disorders. So in general, methadone must be prescribed by a medical doctor and dispensed by a pharmacist under very strict regulations and policies. And the regulations are extensive, and our programs cannot actually be, MMT program can't be prescribed by anyone except trained pharmacists, doctors, and clinics. So why methadone? Why was this drug chosen as a treatment for opioid addiction? So it has to do with the properties of methadone being long-acting versus short-acting. So long-acting means that the drug acts more slowly in the body and for a longer period of time. So methadone is a long-acting opioid, and essentially the effects of methadone will last anywhere from 24 to 36 hours depending on the dosage. So the theory and the belief behind this is that a person who is addicted to short-acting opioids, such as heroin, oxycodone, fentanyl, or hydromorphine, will use methadone as a replacement to those short-acting opioids, and thus they will not continually go into a severe withdrawal symptoms every few hours, and the methadone will keep them feeling comfortable, and they won't experience those intense cravings for those short-acting opioids. So how it works. Methadone, as we mentioned, it offers a break in the cycle of the opiate addiction. So it satisfies the brain's need for the opiates and the accompanying high. So it's taken orally once per day, and methadone binds to the opiate receptors. So again, satisfying the strong physical cravings that a person using opioids would have. And as I mentioned before, it is only administered in specially certified methadone maintenance therapy clinics and pharmacies. And methadone is actually used for both inpatient and outpatient treatment, meaning that is widely accepted as an addiction by addiction centers, inpatient treatments such as 28-day, 60-day programs. So the MMT therapy can be used in treatment settings and also for outpatients. So one of the things that prompted me to have an interest in this topic is that I would hear residents in my agency talking about getting their carries, and I really didn't know what they were talking about. So some of the slang surrounding methadone is very interesting. A carry or carries is where a person who is on the MMT program and taking methadone will have, if they have earned certain permissions, to take their methadone out from the pharmacy for a couple of days. So this happens like if it's a holiday or the person is going to be away, they can get approval to take the methadone as a carry for a certain amount of time. Methadone needs to be always locked up at all times, and that is one of the large reasons why pharmacists dispense it, because it's a serious and dangerous substance that, if found by a pet or a child or anyone else, can be very dangerous. So the other thing is the slang is drink. They're going to get their drink. Methadose, dollies or dolls, meth, junk, metho, jungle juice, and juice are just a very few examples of some of the common slang surrounding methadone. Drug interactions is very interesting, and I think I just mentioned that it's a very serious substance, usually and generally taken through the MMT program as a liquid, as an orange-colored drink. So mixing methadone with other drugs that depress the central nervous system is very dangerous. So other opioids, alcohol, and benzodiazepines such as Ativan, Xanax, Restorol, Valium, clonazepam. These are all highly prescribed medications, and so the drug interactions with these and methadone are very serious and need to be taken into account. It's especially risky for a person when they first begin the MMT therapy. The reason is that they are likely to, at the beginning of the treatment, still have those cravings for the short-acting opioid, heroin, for example, at the beginning. So there is a real risk at the beginning of their MMT treatment that they would relapse to the short-acting opioid, and that can cause serious overdose and serious illness or death. So the other reason is that taking other opioids while you're on the MMT treatment can cause the methadone to wear off quickly, and then you can experience your typical opioid withdrawal syndrome. Some of the side effects that are associated with methadone are constipation, excessive sweating, dry mouth, changes in sex drive, drowsiness, lightheadedness, nausea, vomiting, and weight gain. So methadone has been highly studied and highly regulated. Just synthesizing some of the major studies about MMT is most believe that it reduces or eliminates use of opioids, the transmission of diseases, death rates, and criminality associated with addiction. And essentially, patients gain relief from cravings and the withdrawal symptoms, and the euphoric effects of the opioids are blocked. So the chasing the high, that euphoric effect is essentially blocked by the methadone. Benefits, incredible benefits to MMT programs or methadone replacement therapy. Essentially, every dollar spent on MMT translates to anywhere between $4 and $13 of savings for the community. The average cost of an untreated opioid dependency is over $44,000 per year, and the annual cost of MMT per person is $6,000. So we're looking at $44,000 versus $6,000 savings. Now, why did I call my presentation the methadone debate? There is a debate as to whether the MMT therapies is a treatment or is it a new addiction. So people can be on MMT, methadone, from anywhere from 1 to 20 years. And often the debate is, are they now not addicted to the short-acting opioids, but very addicted to the long-acting methadone? And even treatment centers now have particularly targeted treatment for methadone addiction. It's certainly people being on them for up to 5 years, 10 years, 20 years are certainly addicted to methadone. Visually, if people are taking a high dose, they are nodding off. They are exhibiting symptoms of an opioid addiction. So the debate really is, are people on methadone or taking the MMT treatment, are they sober or not? And who knows? I don't know, and I don't know what the answer would be. I know that looking at all the information, that this is the only viable treatment option that we have for people who are addicted to opioids. It's the only thing that is working. It's the only option. But I do believe that perhaps combining the MMT therapy with much more targeted counseling, much more targeted trauma-related interventions, much more social supports, agencies, even things like life skills and job coaching. I really feel like there needs to be more of a wraparound care for people who are on MMT in order for the therapy to be effective, which it is, and then move them away from taking any opioids at all over time. So I don't know, but I was really feel more confident in talking about MMT or methadone, and I do feel that this has been a great learning experience for me. I can take this into my agency and into my future work as a social service worker, and I will be able to come from an approach of knowledge and understanding about what the MMT program is. But I just want to leave my presentation with, what do you think? Do you think that this is a treatment or a new addiction? Thanks for listening.